Hello, everybody. This is Nelson Virgil, founder of excelmail.com and discountedlabs.com. Very happy to have Dr. Ramasamy with us today. He's one of the top urologists and researchers in this country. I've known about him for a while because he was here at Baylor in Houston. But what really caught my attention most of all was the review he published last year on the role of estradiol in male reproductive function. And as we all know, estradiol in role in men there's a lot of confusion, a lot of misconceptions. And we're here, hopefully, to get some of your questions answered by Dr. Ramasamy, who has definitely reviewed most references out there. Dr. Ramasamy is a director of male reproductive medicine and surgery, as well as an assistant professor in the Department of Urology at the University of Miami. As a urologist and microsurgeon, Dr. Ramasamy specializes in the treatment of disorders of male infertility and sexual dysfunction. His clinical research focuses on optimizing techniques for sperm retrieval and identifying factors for successful vasectomy reversal. His laboratory research focuses on using latex cells, stem cells, for the treatment of low testosterone. Very interesting. Dr. Ramasamy completed his urology residency training at Weill Cornell Medical College and New York Presbyterian Hospital. He then completed a National Institute of Health-sponsored fellowship in male reproductive medicine and surgery at Baylor College of Medicine here in Houston. In addition to his clinical accolades, Dr. Ramasamy has been integral to the advancement of male reproductive medicine and surgery. To date, he has published more than 100 manuscripts in peer-reviewed journals and several book chapters. So welcome, Dr. Ramasamy. Thank you for joining us today.
Thank you so much for having me, Nelson.
Yeah, why don't we start and review a little bit of the review. You published this in 2016 on the Asian Journal of Andrology, and it was a very, very good review to read, not too long, on the roles of estradiol. Why don't we start with the first part here, role of estradiol in the brain?
So I think one of the common misconceptions that people often have is that testosterone is often considered as the male hormone and estradiol or estrogen is more considered as a female hormone. So people often think that for men, testosterone is important and women, estrogen is important, and they often forget that estrogen is very, very important in men, as we're going to discuss during this interview today. And at the same time, testosterone is also very important in females and female sexual function. So the proper balance between testosterone and estradiol is, I think, critical, especially in men for both sexual health as well as for reproductive function. So one of the questions that you asked was, what is the role of estrogen in the brain? I think unfortunately, the brain is a very complex organ, and it has several areas which are very critical for the sexual function. People have studied showing that the estrogen receptors and androgen receptors in the brain are critically important in order to have proper libido. In fact, one of the common side effects of a drug called clomiphene citrate, or Clomid, which we use often in men with reproductive abnormalities, men often come to us complaining of impaired libido. I think that was one of the first instances wherein we thought estrogen is probably very important because, as everyone knows, clomiphene actually blocks the action of estrogen on the brain. And once you block the action of estrogen on the brain, the estrogen receptors in the brain do not get activated, and therefore these men complain of impaired libido. This is very interesting because the estrogen levels in men who take Clomid are actually normal or even higher. But unfortunately, the action of estrogen on the brain is blocked. That's what Clomid does. And so therefore, these men, despite having normal levels of estrogen or even high levels of estrogen, will not have the proper libido effects that men who don't take Clomid have. So I think that was one of the first instances where we found out that estrogen is important for libido, sex drive, and sexual function when men who were taking clomiphene or Clomid came and told us that, "Doc, I don't feel good. This is not right." And when you look at their laboratory profile, it'll be perfect. Their testosterones would have gone up, their estrogens would have gone up. appropriately, and we've got medications that we can adjust the estrogen, but they still feel shitty. And this is where we got the clue that estrogen is important, not just levels of estrogen in the blood, but the action of estrogen on the brain is very critical for men to have proper libido and sexual function.
So, doctor, when we say estrogen versus estradiol, what's the difference? I mean, do we use those two terms interchangeably, or?
Yeah, so there are three ways in which estrogen exists within the body. The most common way and the most reliable way of measuring estrogen is the estradiol, which is the active component that acts on the receptors. So when you're ordering an assay in a commercial laboratory, most of the times they are checking estradiol. It's a 17-beta estradiol, which is being checked, even though they tell you estrogen, because the other components do not exist in the blood with a long enough half-life that can be measured. So it's the estradiol that gets measured, and estrogen and estradiol should be used interchangeably, although estrogens can comprise other smaller forms of estradiol, but the estradiol is what we refer to when we refer to estrogens.
And we have seen some data on the fact that the old assay that used to use as reliable as a liquid chromatography spectrometry test.
Right.
So can you tell us a little bit about testing of estradiol in men and the use of the sensitive versus the regular test that we used to use in the past?
So that's very interesting. I mean, I think the bigger problem that we have with the different assays that are being used to test reproductive hormones actually lies with testosterone, because unfortunately testosterone is so variable, not just from assay to assay, but from time to time within the same day and from two different blood samples drawn from the same patient at the same time. Previously, radioimmunoassay was being used a lot, and that was the assay being used by most commercial laboratories. But I think practitioners have come to recognize that LCMS, or liquid chromatography mass spec, is the most accurate way to measure these sex hormones. There has been a big push by the CDC, actually, and by the government to say that these hormones need to be standardized. And so therefore, most commercial laboratories now, both Quest and LabCorp, as far as I know, are doing liquid chromatography mass spec. And patients, whenever they get their blood drawn, should make sure that it's the LCMS assay. And if the RIA assay was being used to measure testosterone and estradiol, they should request it from another laboratory that uses the LCMS assay.
Yeah, we offer the LCMS assay both for testosterone and estradiol on internetLabs.com. And why do you think estradiol is so vilified? I mean, on the forums, I actually run, of course, excelmail.com, but there are many other forums out there where estradiol is being vilified. As men want estradiol to be zero. What do you tell these men?
So, like I said, estradiol has always been thought of as the female sex hormone, right? And high estrogen levels can have negative side effects. In fact, the biggest problem with estrogen came from these hormone replacement trials done back in 2002 and 2003 for women, for postmenopausal women, where estrogen and progesterone were given in combination, and there was an adverse event of increased cardiovascular side effects. And so I think ever since that hormone replacement therapy for estrogen came about, I think estrogen has had a negative connotation in the lay public. And when we translate these findings now to men, high levels of estrogen are bad, right? High levels of estrogen can cause gynecomastia. It can cause excessive weight gain. It can cause excessive fluid retention. It can cause fluid retention can lead to hypertension, and it's associated with blood clots. So elevated levels of estrogen can form blood clots in the legs, in the lungs, called DVT, and pulmonary embolism, can cause atherosclerosis, causing heart attacks and strokes. After you hear all of these side effects, estrogen sounds terrible, right? So all men would absolutely want to have none of these things and would want it down to zero. So, but unfortunately, estrogen also has very good effects. Estrogen is extremely important for bone health, and men who have decreased or undetectable estrogen levels can have bone loss, leading to osteopenia and osteoporosis. That leads to increased fractures. So I think estrogen has a negative connotation because of all of those side effects, but normal levels of estrogen are absolutely important. I think bringing estrogen down to zero and making it undetectable can lead to very harmful effects in men. And so when practitioners are deciding to manage estrogen, they should be very careful and maintain it at normal levels, but not just bring it down to zero just because they see a high level on an assay. And anytime you see a high level on an assay, the first thing you have to suspect is the assay and not the drug or the patient's condition. Repeat the blood test. Repeat the blood test from an LCMS assay, like you said. Make sure that it's accurate before you start giving a medicine and start treating it. Because once you start interfering with the physiology and start giving a medicine and start intervening, you've lost that normal, the first baseline level that you started with. Because once you give a drug, it's going to change the level and you no longer have what the baseline estradiol level was. Yeah. So yes, estrogen should be low, but should not be zero.
Yeah, and that's a question I always get, what the optimal levels, but obviously that depends on the testosterone level, since 0.3% of testosterone aromatizes to estradiol, right? And so obviously somebody with 500 nanograms of testosterone will have a different amount of estradiol than somebody with 1,000, which is on testosterone replacement probably. So that's something that most guys in my world don't seem to understand. Obviously, there's some references that talk about the ratio of testosterone estradiol, what's a healthy ratio for not only fertility, but also for libido. One of the main complaints on my forum for those that took higher doses of anastrozole, for instance, that some doctors are prescribing 1 milligram every day or 1 milligram 3 times a week, which I think is crazy. And obviously they get to estradiol level that is undetectable. They get obviously lots of libido, lots of sensitivity in the penis area, achiness, joint aches.
Right.
That's a normal complaint, really. The biggest one actually is the joint aches. They can't work out, they're all sore. So at least we're seeing those 3. And my main concern is that as patients are very freaked out about getting gynecomastia. And
right.
Gynecomastia, especially when you're on testosterone replacement, like most of my viewers are, is rare.
Right.
You know, gynecomastia is not all related to estradiol, but everything else that is. So let's talk a little bit about the fears of gynecomastia before we move on, because I think that drives that obsession of estradiol.
So this is interesting. So men on testosterone therapy can have gynecomastia as a side effect. But in fact, most men with gynecomastia do not have an abnormal estrogen level, right? So as soon as practitioners see gynecomastia and start seeing an estrogen level that's within the normal limits, they think that estrogen level needs to come down to zero. And so they use anastrozole to bring that estrogen level down to zero, and the gynecomastia has not changed at all. So for men with gynecomastia who have normal estrogen levels, I use a drug called tamoxifen. Tamoxifen is a selective estrogen receptor modulator, but unlike clomiphene, it works more peripherally than centrally. So clomiphene blocks the estrogen feedback on the brain, and tamoxifen blocks the estrogen feedback in the peripheral tissues. So I use 20 milligrams twice a day for men who have gynecomastia, but who have a normal estradiol level. And let's get into this concept of normal estradiol level. What is normal, and when should we treat, and how should we treat this? So you're absolutely right. As the testosterone level goes up, estrogen levels go up. Some men have an altered ratio in which their estrogen levels are high with a low testosterone level, and that's easy to treat. You start with blocking the conversion of testosterone to estrogen to see if the testosterone would go up and the estrogen would go down. But in men who are on testosterone therapy, who have ranges anywhere between 500 to 1,000 nanograms, I only start treating estradiol only if it's above 60 picograms per ml. So if it's above 60, I use 1 milligram of anastrozole once a week. And normally, with just that once a week dose, the estrogen levels usually go down to normal between less than 50 is my acceptable normal. If it's above 80, so if the estradiol is above 80 picograms per ml, then I use 1 milligram twice a week, or that's the most I do. And it doesn't matter what it is, it's 100, whatever it is, usually 1 milligram twice a week will get people back down to the normal range. I think using the 1 milligram once a day literature of using Arimidex comes from the female breast cancer literature, wherein 1 milligram anastrozole once a day has been used to prevent breast cancer occurrence. And so obviously there, it's a very important indication wherein you're trying to prevent all the estrogen from acting on any of the estrogen receptors for breast cancer. But in men, I think using that same dose is totally inappropriate, because over there, you're trying to basically block all estrogen from acting. Over here, you're trying to bring estrogen down to normal levels, but you're not trying to bring it down to zero. So I think it's very important to understand that use of anastrozole should be used carefully, like the doses that you mentioned. It's either 1 milligram once a week or 1 milligram twice a week at the most. And the goal should never be never to bring it down to undetectable levels, but to bring it down to the normal range. And using for gynecomastia is a side effect of testosterone therapy. Men should be aware of it. It can happen in the absence of elevated estrogen. If the estrogen is high, then that's what I would go first. I would not start with tamoxifen. But if the estrogen level comes back normal, then I would use tamoxifen 20 milligrams twice a day, and most men seem to do very well with it. Rarely do they need to go and get surgery, but that's very unusual.
Yeah, I've seen the same. And what's bothering me right now, and I get to hear everything about, out of the field, obviously, because I have 15,000 people are posting on my site. Some clinics are starting men at baseline with anastrozole. They don't even wait to week 8 to 12 to follow up on what levels they have. So that bothers me. That's happening more than you think.
Right.
And is more common.
It's the same. Unfortunately, it's the same trend with testosterone, right?
Yeah, that's true. That's true.
I mean, you're taking it a step further with estrogen, but I mean, come on, we should talk about testosterone, wherein clinics are giving out testosterone injections or any testosterone replacement without checking a testosterone level to see if it's abnormal or not.
And I've had some private conversations with doctors, obviously, that are doing that. They're friends of mine, and they tell me, Nelson, the biggest thing that I'm trying to avoid is getting emails and calls during the first 2 weeks of treatment, of testosterone treatment, where a man thinks they're going to get gyno and their nipples are starting to itch. So it becomes almost like a management issue for me. And I prescribe it on baseline, and then a follow-up, if the estradiol is too low, I change the dose or whatever. So people are doing this for a certain issue, and mostly not getting phone calls or emails in the first few weeks. So I can see but it's really an issue. Another thing about gynecomastia, I've been reading all the references. There is actually a good reference in teenagers where their estradiol and testosterone were pretty much normal in the normal ratio, but IGF-1 was elevated. So there's a growth factor there too that has nothing to do with sex hormones. So I tell the guys, there are many factors involving gynecomastia is really rare. And let's jump at the next thing. When somebody has an 80 picograms per milliliter estradiol, let's say their testosterone is 700, which is good level. What are the reasons? Is it liver metabolism, too much fat? What are usually the reasons why estradiol may be high in a certain man with normal testosterone?
So a very good question. I mean, some people aromatize better than the others, right? And most of the aromatase, in fact, is in the testis. I mean, testosterone gets produced from the testis. There are cells outside the germ cells called Leydig cells, which have aromatase. Some men have more aromatase and they quickly switch it to estrogen. Some men have less aromatase. And basically that's what drives the difference. Being fat sometimes, and I've never found this association to be true. People always say, oh, fat people have more estrogen. Not true. You see some very thin people with like very high estradiol levels and some very fat people with very low estradiol levels. So this whole concept of, oh yes, you have more fat, so you're going to switch more of your testosterone to estradiol, doesn't seem to pan out in clinical practice. So it really depends on underlying genetic variations and how good you aromatize versus some people that don't, is what drives some men to have elevated estrogens and some don't. I mean, we've all seen this. I mean, some guys with 1100 testosterone on testosterone injections, their estrogens come back at 30. And some guys at like 500 nanograms and their estrogens are like 90. And so it all depends on how good or bad your aromatase enzyme works, and it's probably the underlying genetic differences that change between the two.
I have another practical question that I haven't found a doctor to answer.
Sure.
We say that high estradiol can cause water retention, obviously.
Yes.
But I ask doctors, okay, so when you give a patient an anastrozole, do they lose water weight? I can't get a straight answer, even from my forums. Guys cannot tell me whether or not they lost water weight due to an anastrozole. Have you seen that?
So testosterone itself can also cause water weight, right? So that's the conflicting issue here. So is it the estrogen that's causing the water retention, or is the testosterone causing it? Both of them, unfortunately, work in the same around the same receptor. So that's what the challenge is. But absolutely, I mean, if the estrogen is high and they have the side effects of the high estrogen, if you give an anastrozole, it should work. But the problem is, most doctors would be scared of that and would drop the testosterone dose as well, in addition to the Arimidex. So you don't know which one caused what. But no, absolutely. If the testosterone level is in the normal range and the estrogen is high, and you have given and they're complaining about water retention, and you've given the aromatase and now the estrogen drops, most men will be happy. You will see that weight loss happen very quickly.
And let's jump into libido, sex drive, and estradiol. So you published, I think it was a poster, right, at Baylor, that showed that people were against. I mean, I posted that poster on my sites, and people were not happy when you're telling them that guys with higher anastrozole were having better libido, but everything else, consider everything else normal. Can you tell us a little bit about that? Was it a poster presentation?
No, it was actually a publication in European Urology that we showed that men on testosterone therapy who actually had elevated levels of estrogen actually reported higher levels of libido compared to men on lower estrogen levels. So the concept being that in men who had normal testosterone levels on testosterone therapy, despite having lower estrogen levels, had lower libido. And so this was interesting because the idea for this study actually came from the New England Journal of Medicine paper by Finkelstein, wherein he gave young college grads, he gave them Lupron, which basically blocks off LH and FSH. Very hard study to do. I don't know how people volunteered for this.
Money.
It gave us very good information, because when he gave back testosterone, but at the same time blocked their estrogen, by giving them Arimidex, and there the dose was very high, gave them 1 milligram once a day, their sex drive did not come up despite normal testosterone levels. They recovered normally, their testosterone kept going up, but in the group that was given Arimidex, their sex drive did not improve. So I extrapolated the idea to say, oh, so if this happens in young, normal college kids, what happens in men who get testosterone therapy? And we used basically that same concept and looked at our patients with Dr. Lipschultz to see if men who were receiving Arimidex or who had a lower estradiol level would report differences in libido, and that's basically what we found. So men on testosterone therapy, their estrogen levels should not just be brought down just because they go off into the abnormal range. You should use it carefully and base it on symptoms.
So estradiol really can be an enhancer of the functions of testosterone, not only of sex drive, but also, and our next subject is mood and brain function, right? At the right levels. There's a reason why nature put that hormone in our bodies, right? In male bodies. So
absolutely.
It is not a hormone that has the brakes on testosterone, but actually can enhance the effect of testosterone. Obviously, high levels of estradiol can decrease testosterone blood levels because of the feedback loop. But let's talk a little bit about the effect on mood. And you have a section here on your paper about serotonin receptors and estradiol. That's also very interesting. The 5-HT2A.
Right. So unfortunately, like I think we had spoken about at the beginning of the interview, the brain is unfortunately still a very complex organ. The limbic system, which drives sex drive and libido, are still pretty unknown in terms of what hormones act and what receptors are important. Combination of serotonin and dopamine are obviously very important neurotransmitters for libido and sex drive. I think one of the studies that basically showed was that estrogen can work its action on serotonin receptors. And so basically is very, very important that estradiol levels are normal for these serotonin receptors to be activated for libido. And so one of the important factors that we mentioned in the paper was that for estrogen levels to be normal, we will need to have serotonin receptors active, and for these estrogen receptors to be active as well.
And another issue that really scares the guys are very tiny versions. Can you talk still?
Yes, I can. But can we pause and re-record at another place? They have a meeting over here.
All right, we're back. So, well, Dr. Ramasamy is here with us, and we're very honored. I'm very excited because he actually has taken the time to review most papers on estradiol in men. So let's talk a little bit about this study that was also very concerning, very small study actually, a case control study, where men with erectile dysfunction were shown to have more venous leakage if they had higher estradiol blood levels. That really freaked out a few of my readers on excelmale.com. Can we talk a little bit about the pros and cons of that small study?
So it was a very small study in which they had basically looked at men with erectile dysfunction, and they had well documented penile duplex results on. Obviously, for practitioners doing penile duplex, it's an ultrasound study in which an injection of trimix is given right before the ultrasound. Men get a full erection. It's supposed to be a full erection, and then Doppler measurements are made on the blood flow, on the inflow and the outflow inside the penis. Just like any other ultrasound technology or ultrasound study, it's very subjective. And so therefore, most practitioners don't wait till men get 100% erection before doing the ultrasound. And if you do that, and if you don't wait for a full erection, then your venous leak studies could be misinterpreted. So despite all of its subjectivity, it gave us some information that if the estrogen levels are too high, then it can lead to possible venous leak and lead to erectile dysfunction. And the one thing that was missing in this piece is to see what were the testosterone levels, because testosterone levels are very important for erectile function. And low testosterone in its own has been shown to be associated with mild erectile dysfunction. And there are now recent studies showing that unless you have a normal testosterone levels, even medications like Cialis and Viagra will not produce their desired effect. So is estradiol important in erectile function? Absolutely. But the important message there is testosterone is also important. And to have the proper ratio between testosterone and estradiol is very, very critical. And one of the important things that I do in men who have erectile dysfunction, the first thing is I check a testosterone level. And if they have mild erectile dysfunction, doc, I can get away with Cialis and Viagra. Sometimes I don't even start them on Cialis and Viagra, and I just give them testosterone therapy, and that usually does it. In this day and age where we live, we know that Cialis and Viagra is often not covered by insurance, whereas testosterone therapy for men with low testosterone and symptoms are often covered. And most men come back to me very happy saying, doc, I don't need to take Cialis and Viagra anymore. I don't need to spend as much money to have good erections anymore. Just the testosterone therapy alone was able to fix that. And I think that's a very important message to convey. This is men specifically in mild erectile dysfunction. However, when you fast forward or move the spectrum a little bit in men who've had radical prostatectomies, men who have diabetes, men who have advanced erectile dysfunction, giving them testosterone therapy and monitoring the testosterone estradiol, not very important. Because now you're talking about non-functioning penile tissue, non-functioning blood vessels inside the penis because of diabetes and prostatectomy and nerves, that there you need to do something to the penis, wherein you treat it with Viagra Cialis or think about intracavernosal injections or even a penile prosthesis. So role of testosterone therapy, and erectile function, I think it's very important in men who have mild ED. Mild erectile dysfunction can get away with Cialis and Viagra, sometimes doing it without Cialis and Viagra. In men with advanced ED, testosterone, estrogen, not very important.
Yeah, and I also find out that most men do not know that some of the medications they're taking may be affecting their erectile function and libido as we get older, you know?
Absolutely.
Blood pressure medications, statins,
antidepressants,
even Tagamet, which is an anti-acid.
Right.
Many things or antidepressants,
Mm.
so. There's always this war in the environment against having a good erection because there are so many factors involved there, not only psychological, but also biochemical and medication related.
Right.
Just before we jump, because I'm going to forget, and a lot of people are asking me about what's coming up in the future. You're doing some stem cell research with your folks for erectile dysfunction. Can you tell us a little bit about that work and where it's heading? And how much more time before we see something in humans?
Sure. So hopefully not long. So one of the studies that we're doing, and we're doing this in animals right now, but we actually plan to apply for a clinical trial very soon, is to use Lytic stem cells. So men who are aging and have low testosterone have cells inside their testicles called Lytic stem cells. So these are stem cells that have not differentiated and matured into adult cells. We're trying to see if we can get a biopsy of the testis and expand these cells outside, so in vitro, so expand the cells from 100 cells to a few million cells and graft it, meaning inject it under the skin. No man will want to have their testis injected, so we're trying to see if this would work under the skin. The goal being your testosterone would go up, but more importantly, your FSH and LH and the estrogen and the hormonal axis will not be disrupted with these therapies. Because most of the testosterone therapies, as we all know, is a contraceptive, blocks the FSH and LH, and your whole axis is disrupted. And hence, I think we lead to a lot of these side effects of weight gain, water retention, hypertension, erythrocytosis, polycythemia, and so on. So if we can somehow maintain this axis with FSH, LH, testosterone, it goes up, and the body knows when to shut the testosterone down, I think it'll be fascinating. So in this summer, I hope we've applied for a provisional patent, which has now gone through. And we're now submitting an IND to the FDA. So it's basically a clinical trial to be able to do this in humans. So yes, we are 5-10 years away, but at least to do the clinical trial, I think we're hopefully a year or two away.
So, but results in what, mice? Is that what you use right now?
Right now we're doing this in mice, but we've also taken human biopsies and grafted them in mice, and we've shown that works. So now we've got to do it from human to human. And the reason we're doing it in the same person is so we never have this problem of, immunology, wherein there's different antibodies that could work against these stem cells.
Well, we're excited. I mean, we'll definitely have another webinar when you have more data to share. How about the role of estradiol in sperm, not only quantity but quality in men?
So both, like I said, both testosterone and estradiol are extremely critical. I think when people have been blocked with estrogen and never have very, very low levels of estrogen, their sperm, not just the concentration, but their motility and the quality has been shown to be very poor. So in fact, in men who have very high levels of estrogen, just like you talked about erectile dysfunction, their sperm concentration and quality is also very low. So it has to be optimal. You cannot bring it down to 0, and you cannot have it more than 80 or 90 picograms per ml. It's got to be somewhere in this normal range. And the ideal, I think we touched upon this a little bit, the ideal testosterone to estradiol ratio is 10-1. You want testosterone to be 10 times higher than estradiol. In men with infertility, the ratio is altered. So it's usually 5-1. So the estrogen levels are high, and we usually give anastrozole in men with infertility to improve their sperm counts if their estrogen is high or if their testosterone to estradiol ratio is low. So estrogen is very important for sperm. You shouldn't have it too high, and it should not be undetectable either.
Do you only use anastrozole, clomiphene, and tamoxifen? Do you use any other estrogen blockers?
So the only other estrogen blocker that's been used but no longer used is used to be an old drug called testolactone, which has come off the market, but some practitioners use letrozole, and it lasts a little bit longer. I haven't seen much differences between anastrozole and letrozole. Very happy using anastrozole, but letrozole is also used, and those are the only estrogen blockers that are available.
Yeah, some guys are using Aromasin, which is
Aromasin.
Yeah, but that's not FDA approved, right? That's okay.
No, it's not. No.
Yeah, they swear by it, but hey, I'm becoming the anti-estradiol overdosing.
It sounds like it. Yeah, it sounds like it.
talk to online. So I'm the only one speaking about this problem that we're seeing everywhere with clinics giving anastrozole like candy.
Right.
So last but not least, let's cover two things: the bone mineral density issue in estradiol, and any issues when it comes to lipids and cardiovascular, either through the estradiol effect or too much anastrozole. Will that affect heart disease also?
Right. So so high levels of estrogen have been associated with atherosclerosis. One of the reasons why hormone replacement in postmenopausal women became such a hot topic, because it was associated with increased risk of heart attacks and strokes, thought to be leading from either elevated thrombosis, from platelet dysfunction, or from atherosclerosis because of lipid dysfunction. So I think normal levels of estrogen, at least for that, should be maintained, and to maintain proper lipid physiology. As far as bone health is concerned, I think it's extremely important. Men often think that they're going to fall and die of fractures when they become 90 years old. I think that's not true. If you go on anastrozole for 3 months, just 3 months, 1 milligrams once a day, people have shown that you already have bone loss on a DEXA scan. And so it's extremely important. Men with low testosterone have had increased risk of osteoporosis and fractures because of that, because you don't have enough testosterone, you don't make enough estrogen, and you lead to bone fractures. So I think it's very important that men and practitioners who are just listening to understand that bringing estrogen down to undetectable levels, keeping them at undetectable levels long-term can lead to irreversible bone loss. Because once that bone is lost, you're not getting it back. You could supplement with estrogen, turn off the anastrozole, but what we should all be wary of and scared of are these irreversible side effects that we cannot gain, and bone loss is certainly one of them.
Well, I guess we covered enough ground. It's almost an hour, so we're going to be posting this video on YouTube. I'm going to be getting it transcribed so people can read the content too. And please promise me that this is not going to be the first or last, the last one. We can do another topic like the use of HCG.
Yeah,
and we're involved in that research too, and that's another hot topic. So maybe next time we can talk about HCG and sexual function and testicular atrophy and all that, and fertility. So
absolutely. Listen, thank you very much for having me. I think the message that needs to get conveyed is that, and this is probably true for everything in life, right? Too high is not good, and too low is not good either, right? Everything in moderation is probably perfect. And I think that's the message that needs to be conveyed with estrogen. Too high, not good. Too low is not good either. And just taking anastrozole from the get-go without checking estrogen levels and not worrying about the side effects is not a good thing either. So thanks for having me, and I hope we've conveyed that message through.
Thank you so much, and we'll see you soon, okay?
Okay, bye-bye.
Bye-bye.